Clinical and precise. Calciferol is a steroidal pro-hormone. Unlike a simple dietary vitamin, it requires a specific, multi-stage activation sequence before the body can utilize it. Despite this complexity, standard diagnostic protocols rely on measuring exactly one biological marker, 25-hydroxyvitamin D. When a patient's lab results drop below the accepted clinical threshold of 30 nanograms per milliliter, the standard operating procedure is impressive counterdosing. Physicians routinely prescribe 50,000 international units of D3 per week to correct the perceived deficit. Patient A receives heavy D3 supplementation, climbing from 11 nanograms into a secure 60 nanogram range, resolving symptoms. But patient B undergoes identical dosing, yet their baseline flatlines. Instead of rising reserves, their systemic inflammation markers aggressively climb. This single biomarker approach leaves a diagnostic blind spot. It misinterprets complex metabolic sinks as simple nutritional deficiencies, missing patients whose bodies are processing the hormone in an entirely different biological direction. Isolating the failure point for non-responsive patients requires mapping the pharmacokinetic pathway of calciferol. The process begins with an input. Raw cholecalciferol, or D3, enters the system through either ultraviolet skin synthesis or intestinal absorption. Because D3 is fat-soluble, intestinal absorption introduces a bottleneck. Oral supplementation requires optimal gallbladder function and robust bile production to extract the molecule. Once absorbed, raw D3 travels to the liver, transforming into the 25-hydroxy inactive storage reservoir, the only metric measured in standard panels. The reserve then travels to the kidneys for activation, a final conversion strictly dependent on magnesium. This produces 1,25-hydroxyvitamin D, the active hormone. Raw D3 inputs cannot mechanically translate into an active hormonal output without these prerequisites, specifically functional bile and adequate magnesium. Once active, 125-OHD travels to vitamin D receptors located on lymphocytes, dendritic cells, and macrophages. These cells coordinate the Th1 immune pathway, which acts as the aggressive defense mechanism against acute viral and bacterial infections. They also manage the Th2 pathway, the humoral response responsible for antibodies and immunological memory. T regulatory cells act as the biological referees between these two systems, preventing either pathway from dominating. They are entirely dependent on active vitamin D binding to their receptors to maintain this equilibrium. The proof of this regulatory mechanism was established in a landmark clinical trial conducted in Boston. Researchers managed a 5-year double-blind study involving nearly 26,000 participants over the age of 50. The trial tracked daily vitamin D3 and marine omega-3 supplementation against placebo groups. The data showed that optimized calciferol pathways resulted in a statistically significant 22% reduction in autoimmune disease incidence. Beyond bone density, active vitamin D functions as the master immunological governor that prevents autoimmune cascades. We can now define the specific variables that characterize the inflamed phenotype of patient B. These individuals are often dealing with stealth viral infections, active autoimmune flares, or genetic polymorphisms in their receptors. Under these conditions, the immune system triggers a physiological override. Localized immune cells, such as alveolar macrophages in the lungs, possess their own 1-alpha hydroxylase enzymes. These cells can independently convert the inactive reservoir directly into the active hormone, completely bypassing the need for kidney processing. This creates a sinkhole effect. A highly inflamed immune system demands massive amounts of active vitamin D. This aggressive localized conversion cannibalizes the inactive reservoir to fuel the active pool, causing the standard blood marker to plummet. The diagnostic error occurs when a clinician interprets this low score as a lack of nutritional supply, missing the reality of hyperconsumption. If a clinician prescribes 50,000 units of D3 to a patient in this state, the biological consequences are significant. The influx of raw pro-hormone provides unlimited fuel to the localized immune cells. It accelerates the inflammatory cascade rather than refilling the reservoir. In inflamed populations, a persistently low inactive score represents the biological exhaust of an overworked immune system burning through its regulatory reserves. Correcting these outcomes requires replacing the single biomarker approach with a branching decision tree. Step 1 for B-sign, non-inflamed patients remains the same: conduct the initial test for the inactive 25-hydroxy fraction. For these patients, pairing therapeutic D3 with its essential cofactors, magnesium for conversion and K2 for calcium buffering, is mandatory. The optimized target for this group pushes past the outdated 30 nanogram minimum, aiming instead for 60 to 80 nanograms per milliliter. A strict retesting mandate every 4 to 6 weeks is necessary to verify metabolic compliance. If the 25-hydroxy level remains stagnant or drops despite heavy supplementation, the algorithm must branch. The clinician should immediately trigger a secondary blood panel to test the active 125-hydroxy fraction. An inverse ratio, low inactive levels paired with elevated active levels, is the definitive biomarker for underlying systemic inflammation or genetic receptor polymorphism. The goal is to stop blindly forcing biomarker compliance with excessive dosing. Instead, clinicians should use the active hormone ratio to hunt down the inflammatory drivers consuming the patient's biological reserves.